Assalamu alaikum. Thank you, Dr. Sita, for the introduction. Thank you for attending my lecture today. Today, I will be presenting medication-induced ophthalmic toxicity. While the medications that the patient used, they are having beneficial therapeutic outcome for the intended indication, them having systemic adverse reactions, and some of them, they will have some ocular adverse reactions and toxicity. And some of them will affect the multiple layers on the eye. So in the today presentation, I will describe these medications. What are the drug-induced ocular disorders? What are the clinical features of these adverse reactions? What are the possible mechanism of these reactions? And what are the suggestive management point to deal with these effects? So first of all, medication-induced ophthalmic toxicity represent a clinically significant and often under-recognized cause for visual morbidities. And they have a potential to affect every anatomical tear film and the cornea going to the retina to the optic nerve. And the adverse effects from these medications are dynamics, having a dynamic mechanism. It can be due to relative dose related toxicity, maybe due to immune mediated reactions, due to mitochondrial dysfunctions. And in some cases, these toxicities may be precede or come before the systemic toxicity. So they may be a marker or a sign of systemic toxicity. So our role is to early recognize these medications and the side effects, which is very critical, because some adverse reactions are reversible, but the others are irreversible, and with the discontinuation is very important. As you all know, we have a corneal barrier, we have a blood aqueous barrier, and we have a blood retinal barriers. All of these barriers are barriers to protect the eye from any substance to reach inside the eye. But some medications or some substances, they can bypass the junctions in those barriers and can go to the eye and lead to the ocular effect. So today I will present those diseases, those ocular diseases. I will start with medication-induced glaucoma, retinopathy, intraoperative floppy iris syndrome, optic neuropathy, and corneal deposit. So our presentation today, it will be beneficial for all the specialties in our hospital, inshallah. So let's start with medication-induced glaucoma. This is a list of the medications that have effect on open-angle glaucoma. As you all know that corticosteroids may increase the risk of open-angle glaucoma, but beta blockers, they are may used for treatment or decrease open-angle glaucoma. There are some medications may decrease the risk of open-angle glaucoma, but actually the literature for those medications is minor, and we need more investigations. I will talk about some of them in the next slide. We have metformin, statin, bupropion, which is a medication used for depression, selective serotonin reuptake inhibitors, postmenopausal hormone, which is used for postmenopausal symptoms, and cannabinoids. And something interesting, that some medications have a mixed effect and mixed finding for the open-angle glaucoma, such as calcium channel blocker, which are used for hypertension treatment. This table shows the medication that increase the risk of acute closure angle glaucoma. I will talk about anticholinergic medications. Also, we have adrenergics such as epinephrine, norepinephrine, albuterol. For the sulfonamide, also I will talk about them in the next slide. And also we have anticoagulants, which can lead to hemorrhage in the retina, and hemorrhage inside the eye, and will lead to increase the intraocular pressure. Let's start with the anticholinergic effect. Majority of the medications and majority of the classes, they will have the anticholinergic effect. And it can cause angle closure glaucoma by inhibiting the muscarinic receptor and leading to ciliary muscle relaxation and mydriasis, which lead to aqueous blockage, which will increase the intraocular pressure. One class of the medication that have anticholinergic effect are the psychotropic medications. We have tricyclic antidepressants, selective norepinephrine reuptake inhibitors, and benzodiazepine. These medications will block the will lead to papillary blockage and mydriasis, and thus it will increase the intraocular pressure. Also, topiramate, it is a medication used as anti-seizure and for migraine, and it will lead to increased intraocular pressure by ciliary body swelling. And something interesting that SSRI have serotonergic effect, which lead to reduce the aqueous humor production and increase the aqueous outflow. So it has a positive effect on the eye. So this is a meta-analysis of the effect of psychotropic medications and glaucoma risk in intraocular pressure. We'll start with the first class of medications, selective serotonin reuptake inhibitor. They include fluoxetine, cetirizine, citalopram, and paroxetine. And these medications will lead to lower the risk of open-angle glaucoma and a reduction in the IOP, but it is a small reduction and it's consistent. So we can say that there is a protective role of selective serotonin reuptake inhibitor of using SSRIs. For the closure angle glaucoma, we know that those medications have anticholinergic effect, so they will cause mydriasis, but actually this mydriasis and will not significantly increase the intraocular pressure, so it will not lead to acute angle closure glaucoma. So from this slide, I want to highlight that some pharmacological effects will not represent clinically. So the drug mechanism alone does not equal the clinical outcomes for all medications. The next class is tricyclic antidepressant. It includes amitriptyline, nortriptyline, imipramine, and clomipramine. They have been historically linked to glaucoma onset, especially when they are used in high-risk population. So these are two articles in the 1966 and 1987. But in this meta-analysis, the pooled analysis showed that there is no significant result between TCAs and glaucoma. And most of the glaucoma guidelines point toward the induction effect of these compounds in acute closure glaucoma due to the anticholinergic effect. So the evidence with tricyclic antidepressant is controversial. So we have to be cautious when we are dealing with patients treated with tricyclic antidepressant. Let's go to the next class of medications, which is benzodiazepine and Z drugs. Benzodiazepine is a class of medications used to treat anxiety, insomnia, seizure, acute muscle spasm, and Z drugs. They are a safer option for the treatment of insomnia. And from its name, it's Z drugs. They are containing Z letter, zolpidem, zoliplam, and S-zoliplam. And those two classes of medication, they increase the risk of overall glaucoma. For the benzodiazepine, we have short-acting, intermediate-acting, and long-acting benzodiazepine, and the literature said that the short-acting benzodiazepine having a higher incidence of increasing the IOP comparing to the long-acting benzodiazepine. So this showed that the effect of benzodiazepine is dynamic and it's not due to drug accumulation. So also we have to do careful ocular monitoring for patients on benzodiazepine and Z drugs. The next class is the sulfa derivatives. Actually, sulfa derivatives will have two effects on the eye: acute angle closure glaucoma and severe immune-mediated reactions such as Stevens-Johnson syndrome, ocular surface damage. Sulfonamides first described in 1962, and they contain a huge number of medications. This is a list of all the medications from used for different indications. Some of the sulfa drugs are antibiotics, such as sulfamethoxazole. Some of them are diuretics, such as furosemide, hydrochlorothiazide. We have also sulfa drugs are considered anti-inflammatory and anti-epileptic medications such as topiramate. So we will have patients on sulfa drug for many indications. The mechanism of ocular effect of sulfa drugs is due to thickening and displacement of the lens iris diaphragm, and also they will lead to ciliary body edema, which lead to anterior ciliary body rotation. Regarding the Stevens-Johnson syndrome, it is an immune-mediated keratocyte apoptosis, lead to multiple complications such as conjunctival inflammation, corneal epithelial loss, symphylliferam formation, limbal stem cell deficiency, and chronic dry eye. I want to talk about one medication, including to the sulfa drug class, which is topiramate. Topiramate is sulfa drugs used for epilepsy, migraine, neuropathic pain, and weight management. The mechanism of angle closure due to topiramate is idiosyncratic. Idiosyncratic means that it's not dose-related, and some patients will not have it at all, but it may occur in some individual, and often it's related to genetic or metabolic defect. So it's idiosyncratic ciliocoroidal effusion, lead to anterior displacement of the ciliary body, forward shift of the lens iris diaphragm, and acute elevation in the IOP. Clinically, it appears bilaterally, and it will lead to acute myopic shift. The onset usually within the first month of initiation. So the FDA label of topiramate, they mentioned that there is a risk of acute myopia, secondary angle closure glaucoma, and visual field defect. And they mentioned that we have to discontinue topiramate as soon as possible when we are handling a patient with ocular toxicity. This is an article, it is a case control study published in American Journal of Ophthalmology. They reported 49 cases of topiramate-induced acute closure glaucoma, and the risk was higher, 5 times higher in patients younger than 50 years old. And the onset typically within the first 2 weeks of initiation. There is a small percentage of patients having an acute increase in the IOP after doubling the dose of topiramate. Also, there is a refractive effect. It causes myopia up to 8.7 diopter can be induced, and it may take weeks to resolve after drug discontinuation. This is a case report and case series which published by some of the ophthalmologists in our hospital, talking about topiramate-induced acute angle glaucoma. They mentioned 77 cases. The daily dose average from 12 milligram up to 200 milligram per day, and the mean onset of developing the glaucoma around 2 weeks. All cases in this report treated or managed by the immediate discontinuation of topiramate. Also topical therapy. 66% used systemic medications, and few patients, 13%, underwent laser or surgical intervention. The mean duration of resolution of topiramate-induced glaucoma was around 4 days, ranging from 1 to 18 days. One report in this article mentioned that there is a delay onset topiramate-induced acute angle closure glaucoma after 262 days of starting topiramate. For the screening, we have to take a baseline evaluation, and the routine review is not recommended, but we have to warn the patient about the side effects and the symptoms of the eye to seek immediate ophthalmic review. So medications cause glaucoma should be ruled out in any patient presented with acute angle glaucoma by asking or taking the medical history of the patient. One interesting class of medication that found to be linked to improvement of the glaucoma is the hormonal replacement therapy. So why estrogen have an effect? Because in the retinal ganglial cell, it contains estrogen receptors. So estrogen may provide neuroprotective, it reduces oxidative stress, improve ocular perfusion, and macular apoptotic pathway. But actually, this effect was not statistically significant. Use and the glaucoma protection. And one study showed that the early menopause, in age before 45 years old, increased the risk of open-angle glaucoma. And the late menarche lead in age more than 13 years lead to open-angle glaucoma also. So maybe this is a proposed question. Lower lifetime estrogen exposure will lead to higher glaucoma risk. And this is a question for further research. This is a randomized clinical trial about the effect of hormonal replacement therapy in intraocular pressure. They have 1,066 8 women. It was a secondary data analysis from an original randomized clinical trial, and they showed that the reduction in the IOP was 0.5 micrometer mercury. This reduction was small, but it was significant. Also, I want to mention that hormonal replacement therapy can lead to dry eye disease, and the risk will increase with longer duration of use. Estrogen only compared with patients who are using combined pills, and it is important in postmenopausal patients who are visiting ophthalmic clinics. Let's go to the next disease, which is retinopathy. I will focus on hydroxychloroquine. Hydroxychloroquine have many or multiple indications. We are using hydroxychloroquine for rheumatological diseases such as systemic lupus erythematosus and rheumatoid arthritis. Also, there are dermatological disorders. We will using hydroxychloroquine, oncology, pediatric patients. So we will use hydroxychloroquine for many indications and diseases. So that's why it's important to know about hydroxychloroquine. Actually, hydroxychloroquine has a favorable long-term safety profile, and the patient will stay on hydroxychloroquine for a long period. And ophthalmologists have to understand why patients are using hydroxychloroquine and what are the risks for ocular toxicity, and what is the appropriate management for those cases. So we have to do screening because the toxicity of hydroxychloroquine is irreversible. This is a recommendation from the American Academy of Ophthalmology, published in 2026, highlighting that there is a retinal toxicity from hydroxychloroquine. So actually the retina will remain normal for many years while the patient on hydroxychloroquine, but there is a point where the signs or symptoms of toxicity will start and deteriorate rapidly. So we have to do the ophthalmic imaging to investigate about the early manifestations of toxicity, which is a retinal thinning. As you can see in the picture, this is the early sign of toxicity, which is the retinal thinning. The pathophysiology beyond that is that this is in the first one, this is the normal retinal pigment epithelium. When hydroxychloroquine enters to the eye, it will bind to this retinal pigment epithelium and also to the melanin, and that will lead to accumulation of hydroxychloroquine inside the retina, and also it will lead to accumulation of the macrophages, which lead to the toxicity and bullseye maculopathy. This is a picture of bullseye maculopathy. And in this chart, I want to highlight that, as I said in the beginning, the patient will be stable for long period, for multiple years, but in one point, when the deterioration starts, there will be a rapid thinning of the retina. In the advanced stages, there will be color vision changes and bullseye maculopathy. And despite discontinuation of hydroxychloroquine, it will be not unreversible and the progression will continue. So our role here is to recognize the inflection point where the retina deteriorates, and then we have to advise the patient about the risk benefit of continuing the medication. The risk factors for having retinopathy when you are using hydroxychloroquine is high dose, more than 5 milligram per kg per day, a longer duration, more than 5 years of duration, renal disease, as renal disease is not uncommon in patients with systemic lupus. So we have many patients with renal diseases. Also liver diseases, tamoxifen use, tamoxifen have a retinal toxicity also. And when we initiate hydroxychloroquine in elderly population, and also if we have already pre-existing retinal disease. The recommended dose of hydroxychloroquine is less than 5 milligram per kg per day using the actual body weight. We have to cap it for 400 milligram per day in obese patients. So to minimize the risk of retinopathy, we have to use the recommended dose and it will allow us to use it for a long period of time. You can see in the graph, even when we are using less than 4 or from 4 to 5 milligram per kg, we will have toxicity, but it will be delayed. But when we started from 5 milligram per kg and started from the beginning with a higher dose, we will expect the toxicity from the beginning. If a patient used hydroxychloroquine for 5 years, the risk of toxicity will be less than 1%. After 10 years, it will be less than 2%. But after 20 years of use, it will jump to 20% risk of having retinal toxicity. After 20 years, if the patient does not have any toxicity, the percentage will reduce to less than 4%. So with the higher doses, we are expecting a life-threatening diseases. Actually, if we are using 6 milligram per kg per day, it will accelerate the risk twice, and the sign of toxicity will appear rapidly, even within the first year. This is a picture of the normal vision and the dark spot that will appear with hydroxychloroquine toxicity. We have to do screening, a baseline screening, so we can compare it with the future images, and annual screening will be needed. Sometimes we can defer the screening after 5 years if the patient have no significant risk factors. So as I mentioned, when we stop hydroxychloroquine, the deterioration will not stop. But if we stop it in the early phase or in the mild onset of the disease, it may lead to improving, but after that, it may lead to central visual loss. So I want to highlight that we have to discontinue the medication as soon as possible. This is a study published in January 2026 about the progression of hydroxychloroquine-induced retinopathy. And as a final result from this study, they found that the progression of the disease will not disappear after discontinuation of the medication. So early detection and intervention before the severe disease is very important. Let's go to the next, intraoperative floppy iris syndrome. So intraoperative floppy iris syndrome was first described in 2005, and it led to complications in the cataract surgery, lead to flaccid iris, which will increase the risk of poor surgical outcomes and long-term visual morbidity. The most commonly medication that induced floppy iris syndrome is selective alpha-1 adrenergic receptor, which is used for treating benign prostatic hyperplasia. So I have a question. Do you know any other indication for alpha-1 adrenergic receptor antagonist other than benign prostatic hyperplasia? One example of this medication is tamsulosin. So did you see any female patient on tamsulosin before? So actually, there are some other indications for tamsulosin to be used for other indications, and all these cases we are using tamsulosin, and the risk for developing intraoperative floppy iris syndrome is more severe in the female population. So why tamsulosin can cause intraoperative floppy iris syndrome? Because it is a receptor, which is a major contributor, 40-fold higher pooled severe risk of floppy iris syndrome comparing to the other alpha blocker agent. Discontinuation of tamsulosin does not reduce the intraoperative floppy iris syndrome, and it can occur due to the chronic structural changes in the iris dilator muscle. So we have to take a proper history from each patient, either male or female. If the male patient mentioned that he had benign prostatic hyperplasia, he is treating now, or in the previous years, we will consider this complication for those patients. And the effect may occur after even a single dose, and it will continue indefinitely. For a physical examination, we can suspect that those patients had a poor pupillary dilation response if they used alpha-1 blocker agent before. So do you have any idea if the other alpha blockers can cause intraoperative floppy iris syndrome? Which one is more significant? Actually, the selective ones are more significant. So tamsulosin is selective, but alpha-zosine is a non-selective alpha-1 receptor antagonist. So that's why they found a statistically significant difference in the probability of floppy iris syndrome between patients who are using those two medications. This is a study of 226 eyes, showed that 34% of the patients on tamsulosin developed floppy iris syndrome, while 16%, the half of them, when they are using alpha-zosine. Another study of 92 eyes showed that 86% of tamsulosin versus only 15% of alpha-zosine users develop floppy iris syndrome. So actually here as ophthalmologists, we are not prescribing those alpha blocker agents for patients, but maybe we can suggest those for patients or ask them before doing any cataract surgery. This is a real-world population-based study. They studied all the medications, all the adverse effects reported to the FDA. They found around 12 million reports, and they studied the floppy iris syndrome side effect. They found it in 649 patients. The highest medications with floppy iris syndrome were imipramine, tamsulosin, and chlorpromazine. And the common thing between these medications is the alpha blocking effect. Something interesting that in female population from this study, they found that brinzolamide and salbutamol associated with floppy iris syndrome, but it was not observed in male population. This is a picture of a table containing all the medications that they found to have a link with floppy iris syndrome. Selective alpha-1 is the most significant. The next one is the non-selective. They have a risk. And the other medications, they found there is a link between floppy iris syndrome and its use, but we have to do a further investigation to see if it's a significant relationship or no. Let's go to the next disease, which is optic neuropathy. I will discuss ethambutol, isoniazid, and linezolid. So ethambutol, it is an antibiotic used to treat mycobacterium infection, either mycobacterium tuberculosis or non-tuberculosis, and it is a metal chelator agent. The prevalence of ethambutol-induced optic neuropathy, about 1 to 2% of the patients, and the risk factors include the dose. Once we increase the dose, the prevalence of the retinopathy will increase. So the normal dose from 15 to 20 milligram per kg per day, and it's associated with 1 to 3%. With the higher doses, which these higher doses will be used for MAC infection, Mycobacterium avian complex infection, so it will associated with higher risk of toxicity. The duration also, it can occur anytime during the treatment course, but the average is between 3 to 5 months. Elderly patient, hypertension, diabetes, renal disease, and also if the patient is taking ethambutol with isoniazid or linezolid. And actually they will, because isoniazid is the first line treatment for TB, and linezolid is considered second line. So they will take them together. The mechanism is that ethambutol is a metal chelator agent. It will chelate copper and zinc, lead to mitochondrial dysfunction and lysosomal dysfunction, lead to optic neuropathy. As a clinical presentation, it will appear bilaterally, but it is subacute and painless. But it will progress to central vision loss. The patient may complain of blurred vision and also color vision impairment. They will have difficulty to distinguish between red and green, which is the most common, and also the blue and yellow colors. And also they may have frequent changes in the glass and contactless prescription. So we have to always do baseline screening, and then every 4 weeks if the dose is more than 15, 3 to 6 months if the dose is lower than this. For the management, unfortunately, there is no treatment, but early detection and stopping of the offending agent, which is ethambutol, is important. If we stop it before the delay of the disease, the vision recovery will occur in around 60% of the patient, but the irreversible vision loss can occur despite the close monitoring and the discontinuation. So actually, the full recovery is rare. And older population have a poor recovery comparing to the younger patients. So there is an interesting method to reduce the toxicity is by using intermittent ethambutol dosing. So it is one of the methods that to treat TB with 3 times weekly administration. And there is a study of 229 patients using ethambutol for MAC infection. They found that the patient who take ethambutol daily, they have 6% of toxicity, while the intermittent duration or therapy, it leads to 0% incidence. So also I mentioned that in MAC infection, we will use ethambutol for long period of time. So we will suspect the toxicity if the patient is treating for other than or non-tuberculosis infections. So from this ethambutol slides, it is common to be used here in the hospital. So we have to take care with those patients. Next medication is linezolid. It is a bacteriostatic antibiotic that is used to treat gram-positive bacteria. This is the table of the indications. It's used for pneumonia, vancomycin-resistant enterococcus, skin soft tissue infection. I want to highlight that the duration of therapy is between 10 to 14 up to 28 days for treatment. So for those infections, linezolid considered to be safe, but the long-term use is the part where the linezolid side effect occurs, such as optic neuropathy, myelosuppression, peripheral neuropathy. So those patients, we have to take care about them because longer duration is associated with higher toxicity. The FDA recommends linezolid to be used for a maximum of 28 days only. And longer duration of treatment will lead to optic and peripheral neuropathy. Clinical trial by Pfizer reported incidence of around 4% of patients will lead to toxicity, while the incidence in other studies reached to 19% if they are used to treat drug-resistant TB. This is the guideline from American Thoracic Society for the treatment of TB. So they are using or they are recommending linezolid to be used in rifampin-resistant population. You can see the dose is 600 milligram daily for 26 weeks, which is much higher or longer than the recommended FDA duration. The mechanism beyond that is linezolid will lead to mitochondrial dysfunction and decrease oxidative phosphorylation, which lead to apoptosis and nerve damage. Patient with pre-existing neurological defects, alcoholic, diabetic, or concurrent use of chemotherapy agent have the higher risk of optic neuropathy. And the optic neuropathy effect of linezolid is reversible. It can recover 3 to 4 months after discontinuation, but the peripheral neuropathy is irreversible. This is a case report of linezolid associated optic neuropathy, and they found that 48 publication before, with the average duration of use of 9 months. Among them, 3 patients developed neuropathy within 4 weeks of use, which is considered the safe duration. Higher doses have a higher optic nerve toxicity, and when we withdraw the medication, the optic nerve injury will improve if the discontinuation occurred before the permanent axonal loss. Around 92% completely resolved, but also the exact duration when the symptoms will recover, it's unknown. In this study, they found it will be recovered after 8 weeks. Let's go to the final disease, which is corneal deposition. I will talk about amiodarone, antimalarial medication, tamoxifen, a non-steroidal anti-inflammatory drug, and isotretinoin. Actually, this is the whole list of medication that can cause corneal deposit, and each medication will affect a layer of the cornea. So let's start with amiodarone. The prevalence of amiodarone corneal deposit is about 98% when we are using it in a dose 200 to 300 milligram per day. And the onset, it may start after 2 weeks, reaching to 4 months. So we have to do baseline screening, and every 4, 8, 12 months, and yearly. Symptoms will usually not lead to visual loss, but the patient will report halos, photophobia, and irritation. The corneal findings, we can find bilateral vortex keratopathy, brown golden deposit, usually bilateral. In severe cases, it will lead to optic neuropathy and optic disc edema. The corneal deposits are reversible, but maybe we have to wait for 20 months after stopping of the medication, and usually no need to discontinue unless we reach to the neuropathy part. For the anti-malaria, we have hydroxychloroquine, chloroquine, amidoquine, and tafenoquine. The onset is about 2 weeks. The toxicity maybe it will be asymptomatic, but it can cause blurred vision and halos. For after discontinuation of anti-malaria medication, it will be reversible, but it will be irreversible with amidoquine and tafenoquine. Tamoxifen, which is a medication used for hormonal sensitive breast cancer, it is estrogen receptor modulator. The therapeutic dose is between 20 to 60 milligram per day, but they will use it for a long period of time. It is a dose-related toxicity. It is a cumulative. If we reach to 7 gram until 100 gram, we can expect the toxicity. Actually, tamoxifen have 2 toxicity, vortex keratopathy and retinal toxicity. So in higher doses, we will expect the retinal toxicity. For the corneal toxicity, we have subepithelial corneal deposit causing reversible vortex keratopathy with no significant impairment of the vision. But the retinal toxicity is vision threatening, and it is associated with higher doses. So we have to do baseline screening, and continuing screening is not recommended if there is absence of signs and symptoms. Actually, tamoxifen can cause more than this. It can cause retinal holes without detachment, retinal pigment change, retinal thrombosis, and so on. So we have to take care when we have any patient with tamoxifen. Chlorpromazine is antipsychotic, and it is dose and duration dependent. It can affect multiple structures of the eye, eyelid, conjunctiva, cornea, and rarely the retina. In this picture, you can see the anterior cataract, and here the second picture, the dust. It can cause anterior lens capsule dusting and corneal stroma pigment dusting. The toxicity, minority of cases can cause vortex keratopathy and may be associated with corneal edema also. The mechanism, it will bind with melanin, and so it will accumulate in the sun-exposed tissue via phototoxic reactions. Even with long-term and low dose or short-term and high dose, it will lead to corneal changes, and generally the pigment deposits are irreversible. Non-steroidal anti-inflammatory drugs, we have naproxen, ibuprofen, indomethacin. So when using these medications, we will expect corneal deposit. The onset rapidly within days of treatment, and it's more common with high doses, ibuprofen 1,200 milligram per day. But actually, the corneal deposit are rare for these medications, and it is reversible within weeks. Rifabutin is also a medication used for the treatment of TB, and it was first reported in immunocompromised children. Actually, rifabutin is used for TB patients who are immunocompromised because of the lower drug-drug interaction compared with rifampicin. It can cause bilateral and initially peripheral corneal deposit, and it's not reversible after discontinuation. This is a picture of the corneal deposit. Actually, there are longer list of medications that can cause ocular toxicity other than what I mentioned. So it is very important to know the medical history and the medication history for each patient we are treating. I just want to highlight that there are also medication can cause dry eye disease. There are many classes of medication actually. So finally, as a take-home message, in ophthalmology, we are protecting vision, but we must also ensure that we are not causing its loss. And if you cannot explain why vision is worsening, always consider the medications. Patients should be educated about the potential visual side effects and seek immediate medical advice if they notice any changes. Early recognition is critical. This is our rule. And screening before symptoms is important. And thank you.
Okay, thank you, Ms. Omnia, for this great lectures. I think it's time for questioning for anybody who wants to ask. So I will start first with the what is other than side effect that you expected usually from medication? Usually it's only affecting the eye. Is it always serious, causing permanent visual loss?
So as I mentioned, some medication can lead to permanent visual loss, but there are some side effects that are not very serious. We can handle it by reducing the dose or reduce the duration. Maybe we can give another alternative for those patients. So some of them are serious, like what I mentioned, but some of them, they are just due to case report or like this.
I see. So let's talk about what, in your opinion, what is the best way to including the monitoring for such serious medication that can harming the eye, and what is the best strategy to making a good screening for patients who's using this medication? Some of them, it's usually chronic.
Well, maybe we can interpret the screening protocol in the system. So if the doctor want to prescribe one of those known medication to cause ocular toxicity, it will appear that they have to do some certain screening before the prescription. Also, there are some medication protocols. We are having them in the pharmacy. We can include this screening in the protocols in the hospital.
I think if we can adding some of these in the electronic health records, making it as a standard practice for us to just or having at least as alert reminder when prescribing this medication. So it's easy for the physician to check if the patient need to monitor this type of medication. It's going to be really good help. So any other questions? Okay, thank you so much. Thank you, Ms. Omnia.
Thank you, Lisa. you.